And I will share the screen.
All right. So today we're going to be talking about harm reduction services. We've got several staff from the outreach team here at NACC who are going to be chatting with us. We already did the prayer and land acknowledgement, introductions, agenda, that sort of thing. You guys have seen this before. We'll just go through the thing. Introductions, as you probably have noticed, Dr. Robbie's not here. I'm Michelle. I'm the nurse manager for the MAT program. So I'm going to kind of be, I don't know, leading the session. And who else normally introduces themselves, Tina, besides you?
I'm sorry. I think that we kind of like skipped over that part.
Yeah.
I think that, yeah, just like the ECHO faculty and staff and then the speakers introduce themselves. So I'll introduce myself. I'm Chyna. I'm the Ryan White non-medical case manager, and I'll pass it off to James to introduce himself.
Hello, my name is James, and I'm HIV community health educator, and I will pass it on to Chyna.
Hi, I'm Chyna Pfeifer. I'm a peer recovery specialist. Yeah, at NACC. And I'll popcorn to Riley.
Hi, I'm Riley. I'm a HIV outreach educator and at NACC. I'll pass it to Nikki.
Hi, I'm Nikki. I am the infectious disease nurse at NACC. I think that's everyone, right?
Yeah.
I think so. Thanks for being patient. I don't know the order that Dr. Robbie normally does this in. So Zoom guidelines, let us know who you are. Introduce yourself in the chat function. Give us your name, title, organization that you work for, and your email. We actually take attendance, and then that's also how you get CEU credit. If we don't have your email, we can't help you get that CEU or CME credit. You can update your name on your screen. Let us know, who you are, where you're from, or put your preferred name on there. And that's just by right-clicking. I think most of us know how to do that by now. Next slide, Tina. Turn on your camera if you don't mind. Even if you're eating or drinking coffee, we like to see you. Mute your microphone when you're not speaking. If we're hearing some noise, we'll go ahead and mute you. Usually if somebody's unmuted and making noise, they don't know they're unmuted. So you can use the chat or you can use the hand raise function if you want to get attention or have a question. And then, as always, no protected health information. Kind of question for our speakers. Do you want folks to save questions for the end, or do you want them to use the chat or have hand raise function during the presentation?
I'm good with like using the chat, and then we would answer questions at the end.
Okay, perfect. All right, next slide. Announcements. We meet the first and third Wednesday at noon. That's Central Standard Time. That sometimes confuses people. And then also it's not every other Wednesday, it's the first and third Wednesday. So sometimes that gets thrown a little off if there's an extra week. Next session, so February 19th, we're going to be talking about ACEs and historical trauma with Susan Bolio. So I know that I personally am looking forward to that one. And then March 2nd is yet to be determined. There's an opioid use disorder education and treatment echo series with Dr. Bell and Dr. Devine, and that happens the first and third Tuesdays. So that information's here. You're welcome to reach out to us at Midwest Tribal if you want to get in touch with more info regarding that one. And then there's a virtual boot camp, which is quite helpful. Those boot camps tend to be pretty informational and a little bit more engaging than that recorded BUPE training you can get online. So next slide. Case presentations. If you want to chat about specific situations or just general situations you're encountering, feel free to reach out to us. Case presentations are a great way for us to kind of learn from each other. We know what we're experiencing here in South Minneapolis. We don't necessarily know what's going on in other parts of the state. And this is just a great way to learn. Continuing ed. So if you give us your email, let us know who you are. We're going to send you an email with an evaluation. It's like a post-session evaluation. Completing that kind of proves or shows, lets us know that you watched the session, and then that information is used then to provide you with CME credit, CEU type stuff. So let us know who you are. And then next slide. There we go. I'm going to hand it over to the NACC outreach team. Take it away, guys.
Great. Thank you, Michelle, for doing all of the intro stuff that Dr. Robbie and I normally do. So this presentation, we're going to cover harm reduction outreach at Native American Community Clinic. Objectives include providing a brief history of harm reduction and syringe exchange services at NACC. We're going to offer a basic description of why syringe services are appropriate in a clinic setting and what supplies are needed to start an in-clinic syringe exchange. And then we're going to lay out current programming, discussing unique benefits as well as the challenges and key learnings. So I'm going to hand it over to Nikki. She's going to talk about NACC's history.
Specifically NACC's history related to harm reduction.
Yes.
NACC started to move towards providing overt harm reduction services sort of amidst the opioid epidemic, the overdose epidemic. So I would say maybe I would trace that back to maybe somewhere in the early 2010s. This was largely driven by clinical health care providers at the clinic shifting their views on working with people who use substances. So kind of shifting from that kind of maybe outdated view of assuming that people who use substances who are coming into a clinical environment aren't really interested in improving their health or engaging in healthcare, but are maybe med seeking or draining resources, and sort of coming into the more realistic, respectful view that anyone can benefit from healthcare services. Everyone deserves healthcare services beyond that abstinence only model. And so the clinic started to ask itself, clinic leadership started to ask itself, how can we create specific healthcare services who designed to support people who are actively using drugs. This was also sort of a step in the direction of thinking about treating the community and the family in addition to just the individual patient, which is really a strength of NACC's. And harm reduction healthcare is really strengths and resilience-based, client-centered, unconditional acceptance, empowerment, individual sort of like self-determined care plans. And I think it's important to know that NACC definitely has always adopted harm reduction principles, insofar as I just described them related to healthcare broadly. And this is kind of more talking about like, syringe exchange, for example, MAT, that kind of thing. Oh, you can go to the next slide, Tina. So in 2016, NACC started delivering Suboxone services, medication-assisted treatment services in partnership with White Earth Nation. Overdose prevention services, distributing naloxone began at about that time. And then syringe services, so actual syringe distribution and exchange began as a grant-funded expansion of our MHE program in 2007. You can go to the next slide, Tina. And so I'm just gonna So what we began doing is offering syringe services on a walk-in basis. And so people could come into the clinic basically anytime they wanted that we were open and ask for syringe services at the front desk. It was very successful. We had a lot of clients seeking that services and, giving us good feedback about the services, but it was just too challenging in terms of logistics. We just didn't have the space for it, and it just became sort of too much for our already full family practice clinic to have happening in the same small space. So unfortunately we stopped doing that walk-in syringe exchange in February 2018, but we did continue to offer syringe services on a walk during clinic appointments and during outreach services. We also started working, we subcontracted with Southside Harm Reduction Services, which was smaller at that point, to continue doing syringe service outreach at the Wall and just in the East Phillips area. And that was a really great partnership because we kind of had at that point, the sort of funding and administrative support of NACC, as well as the grassroots kind of like agility of Southside. So currently, I'm sorry, I'm not going exactly off this slide because this was my fault, but I have an updated slide. So sorry, it's not following exactly as the slide is laid out, but we've evolved quite a bit since then. And so currently what we're doing in terms of syringe services is we are offering syringe services during street outreach, during clinic appointments, and also during designated times. So we have certain spaces in the clinic where people can come in and request syringe services. So right now we're doing it Monday from 11:30 to 2, for example, and we're hoping to expand that. So, and next slide, Tina. So then in terms of adopting a syringe service program in a clinic setting, and I know everybody is going to talk more about this, but just to sort of wrap up what I'm about to talk about. So I think that staff education is one of the most important things, and really having an environment where people feel comfortable sort of voicing all of their opinions, both, really familiar with or excited about syringe exchange, and then also those that are not comfortable or opposed, having either people from outside the clinic or from within the clinic with experience with syringe exchange, doing sort of teach-ins and being available for staff to come ask questions, as well as potentially seeking technical assistance outside of your organization if necessary. So, I mean, if a clinic has people within the clinic who already have experience with syringe services, that's great. If not, though, reaching out to more experienced providers who can help provide you with some of their own experiences can be helpful, and you can certainly reach out to our team about that. There are some practical methods to reducing stigma within already existing programs, like sort of changing language, changing assumptions, trying to reduce barriers to care. So offering drop-in services or flexible hours, and then focusing on really that non-judgmental report, and becoming comfortable talking sort of frankly about substance use. And that is what I have.
Thanks, Nikki. So I'm just going to briefly go over sort of like the case for why syringe exchanges can and should exist in a primary care clinic. Included on this slide are just, these are things that I pulled from the CDC's website, and just to point out that like there's been like tons of research on syringe exchange and the proven effectiveness of them. They are effective at preventing and reducing infectious diseases, preventing other life-threatening infections, illnesses, and injuries related to drug use, preventing overdose, linking people who use drugs to care. For instance, new users of SSPs are 5 times more likely to enter drug treatment and approximately 3 times more likely to stop using drugs. Syringe exchanges also help clinics maintain relationships with their patients. I mean, even if people aren't necessarily making their appointments, syringe exchange and outreach can act kind of as a bridge just to maintain that relationship. And they can also improve public safety via facilitation of safe disposal and just generally educating people about stigma and overdose and the implications of drug use and opioid overdose. So this is all accomplished by offering free and non-judgmental access to supplies, offering a range of supplies that allow different options and alternatives to people who use drugs. For instance, offering foil and other smoking supplies alongside syringes in case people want those alternatives as a harm reduction tool. And then providing education about those supplies, health services, resources, and overdose prevention. And I'm just going to show an image of some of the things that are offered. These are just kind of basic bare bones supplies that we offer. So let's see, what would this be on the left? These are like smoking supplies, so glass stems, these rubber topper buddies to protect people's mouths, lip balm and foil. And then for syringe exchange supplies, these kits include 20 syringes, tourniquets, clean cotton filters that people can use when they're drawing up the drug, cookers, alcohol swabs, condoms, Band-Aids, and sterile water. And we do hand out a lot of biohazard bins as well. And so as Nikki already alluded to, our harm reduction and like syringe services are more so like integrated into the rest of the programs that we have. NACC has a wide spectrum of services, and we don't necessarily like silo this service within like MAT or infectious disease. It's available to everybody. So yeah, I'm going to pass it off to Riley now, and she's going to talk about HIV and hepatitis C testing.
Thank you, Tina. So with being an outreach worker, one of my primary goals or, things that I do is HIV testing alongside with hepatitis C testing. And we offer that once a week during our testing events every Monday from 11:30 to 2, as well as during some of our outreach efforts. Some of the services that are included are the syringe exchanges, which Tina talked about. We have our harm reduction supplies along with dirty needle disposal. Nikki's been doing a lot of COVID vaccines, and we have like food and drinks, warm weather gear. And then something new that we've been doing this last quarter or two is our linkage to care vouchers. And those are something that we hand out to individuals who come during the testing events or on outreach, and they can go to any appointment, which, any of the appointments that were on the last slide that Tina showed. So like behavioral health, medical, or dental. And after they complete an appointment, they can redeem the voucher and get a $25 gift card. And, you know, the main reason for those is just to get them into care and just to be seen, and they've been extremely successful. So we're really happy about that. And, you know, just to the right is an example of a flyer for promoting our testing event. And the next slide, I'm just going to talk a little bit about our outreach testing, which, perfect. So outreach testing at NACC, it's been around for a while, since I believe 2018, but I'd say in the last year, since like 2021 is when we've really increased the numbers due to the outbreak of HIV in like the Twin Cities and in Duluth. So a little bit about it is the tests that we use are the INSTI antibody test. We use these tests as well in the clinic too, but what's really great about these is it takes like no more than a minute. And we also have an OraQuick rapid antibody test, and we would use this if the first one came back positive, and then, you know, we'd go from there with referring for blood work and all of that jazz. But there are little to no barriers for getting an HIV test. They're, you know, less than a minute long, and mainly the biggest thing is getting paperwork done. You know, a consent form, doing a brief screening. Sometimes getting a finger poke done can be a barrier, especially in the colder weather, getting some blood out of somebody or calloused fingers. But other than that, we'll test anybody. But sometimes you have to get creative for privacy, especially on outreach. Personally, I like to use my vehicle. When it's warmer, I like to set up in my trunk, get everything set up, get 2 stools, and then just park away from everybody and just kind of go from there. You can also go inside your vehicle, or another thing that we use at NACC are pop-up fishing ice tents. Those are a really great option. But the main idea is just to make sure that you feel safe and the other participant feels good, and you guys are just away from everybody else. And that is the main key. But as far as challenges, outreach workers in general just face a lot of challenges, especially within the last year. And I know James is going to hit on that a little bit more. But as far as testing goes, I'd say the main challenge we get is with false positives. And I know last year was pretty tough. I know statewide we had some issues. But a false positive is just, you know, when a test comes up positive, when in actuality it is not. So if you see to the right, the photo is an example of the INSTI test. But living in Minnesota, you're either going to have extreme hot or extreme cold. So storing these tests is extremely important, because not only do they need to be stored at a regulated temperature, when you take them out going in the field, they need to be stored in a insulated cooler and be regulated. And you just need to check at the temperature which you take them out of the bag. It can be kind of complicated at times, but very important for the test. And that kind of leads me into my second point is another challenge that we see quite often is, say somebody gets a preliminary positive, which just means that their first test, that INSTI test, it shows that it is positive. Before we do that second test, they might get up and leave. You know, it is a lot of emotion coming to them. It's a lot to take in at first. And some people don't want to stick around for that second test, which is, you know, nothing that we can really do. But, you know, what if it was, and what if that test happened to be a false positive? So that is a challenge that we do face. But moving into that third point, and I know James is going to hit on this too, is just that everyday sort of challenge that we seek as outreach workers, the violence, the evictions, the not being able to find the people that you're looking for. That really does affect us, you know, especially when we're out there trying to test people when there is outbreaks. But I'll leave it on a high note. At NACC, you know, we are extremely well equipped to offer all this testing, whether it's outreach based or in the clinic, because we do have we do offer same day confirmatory testing and really flexible walk-in hours for HIV and Hep C treatment. And we also have the Ryan White non-medical case management services. So with that, I'll pass it off to James.
Hello, my name is James. Again, HIV community health educator at NACC. Just a brief touch up on like what Nikki talked about with the history. I started around the fall of 2018. I was a volunteer with Southside prior to that. And I used to go every Friday morning to the wall, and Southside would be there, and there'd be other folks like Rosemary that was working at Kook at the time. And we'd all kind of like hand out supplies and then do coffee and donuts and stuff, and people really at the wall really appreciated it. Once I started working at NACC, I think we doubled up those days, and so then we were doing actual NACC outreach on Thursdays, and then just going out again, like as with Southside on the Fridays. So one of the things, and I'll talk about why this is important, is it was like a really good centralized area, and even when people did get moved from when the wall closed over to the navigation center, which is what that picture is, we all was able to like know where to find people. Once the navigation center closed, it got more difficult again, because then all of a sudden the camps started just popping up wherever, and then they would start getting displaced. It changed a little again during COVID, and our outreach practices had to change a bit, you know, just due to like safe distancing and so forth. And we're trying to navigate all that, but worked out pretty good. There, like people might have ended up in hotels far away from over here, from where they're generally hanging out at. But there were still like sanctioned camps that we could always go to. Once those dispersed, we're now looking at again this issue of one of the barriers that we run into is like trying to find people. So over, like we basically do the Phillips neighborhood. We're not rarely, I think like lately we've been going to like the Avivo village, but generally we stick around East Phillips and the Phillips neighborhood where we do our outreach. And you can go to the next slide. But even so, like it's still hard to find people if those camps get dispersed, and they're generally getting dispersed about every 1 or 2 months if one pops up. But one thing to always notice is that when people do get dispersed, they always end up back over in this area along the Bloomington corridor, which I and of other people talk to, just to make the sense of when we think about housing or whatever, which is what people really need, is that we really look at like hopefully one day we can really look at low barrier housing for folks that are participants, that are drug users, that might be just doing sex work, where they're not just going to get kicked out like what happened with a lot of those hotels in the past, or they just don't feel comfortable being there, and they can have a place in this area because this is basically their home. Anyhow, so when we're going out, like what Chyna talked about, we offer safe use supplies. I want to talk a little bit about like the smoking supplies, because it really kind of increased over the last couple years. People started requesting more smoking supplies, and for some it might be like, why is the clinic offering smoking supplies? And there's a lot of good reasons for that. And we would talk and ask people like, hey, why do you want like smoking supplies and not syringes, or why you asking for more? And the feedback that I would often get is that people were trying to quit, but they didn't want to. They were trying to quit injecting, but they weren't entirely maybe trying to completely stop, or they were hoping to try completely stop, and or they're like unable to find a vein, which is like what you see around here a lot. Is like you will see jugging where people are injecting in their necks, which is basically their only, basically one of the only veins they have left that they know they can hit. So unfortunately, though, like both NACC and locally and even across nationally, is that most of our SSP funding that allows us to buy syringes don't allow us to buy smoking supplies. So there's been like kind of a real push, and we're really hoping to maybe at one point get the CDC to change that, because not only does it stop the HIV and the hepatitis, or at least reduces HIV and hepatitis C infection that like Riley was talking about, it can also like totally reduce the situation like endocarditis, which I believe Chyna will be talking more about coming up. So huge thing, and it's kind of a positive. It's always, I've been doing harm reduction work for a while, and it's always seemed as a positive if moving harm reduction to go from injecting to smoking, just because it's just safer in so many levels. Beyond that too, we always try to offer education. Back in the day, we used a lot of the harm reduction pamphlets. Over the last 2 years, NACC has finally, like, this is something we wanted to do for a while, is we're starting to develop our own educational materials. And at this point, we have, which I don't have on me right now, but we have a really good overdose prevention pamphlet, and then also one for PrEP. We're in the verge of having a wound care pamphlet done, and then also a more safer injection leaning ones down the road. But when we talk about education too, yeah, always want to go, always ask as much questions as possible. I do think that it's really critical to have like a good understanding, if you're doing this work, of like why you're giving the syringes, why you're having the cottons out to people. So like when people have questions, we're there and we can actually, you know, engage and try to answer those questions at the best of our ability. But at the same time, we also learned a lot from people out there about like the drug trends that's happening, safety issues, where people might be. I know like a couple years ago, we were able to, we heard that there was like people were running out of naloxone, which is also what we offer during outreach, but they're running out of naloxone during at night. So we started creating these little naloxone hubs in areas, and people would pinpoint where they would like those to be. So as much feedback as we can get from folks is really critical. Syringe litters, particularly over here in East Phillips, is a huge thing, and I've worked with both neighbors and local businesses about that. So and one thing too that like we really are kind of believe in is that when I'm handing out a safe use kit and the supplies that Tina show, I'm not just picking up the syringes, I'm picking up everything that might be in that kit when I see it. And that leads actually to volunteer opportunities, because we have had in the past, and I know Southside has in the past too, where we're able to hire participants to help do cleanup. We're working on hiring participants to help pack kits and so forth like that, but that also gives us an opportunity to engage with people more, which I think if we move to the next slide is a real critical piece of the work that we do. And basically it's building connections and relationships. And what did I write here? On top of also, like I do want to mention real quickly, collaborating with other organizations, which we, particularly in the last couple of years, we have done it since I've been around, but especially in the last, last couple of years with the uprising and so forth, a lot of organizations have come together, and we're working together a lot more than we used to, which I think is really important. But also just building those relationships is, and connections with folks who are vulnerable and high risk individuals. And they turn those, we turn those connections into relationships over time. And what our hope and goal is, like kind of what Tina talked about, was we want to create that bridge either between the outreach worker and the folk back to the clinic. And I missed a bunch of stuff like telehealth and stuff that we started offering, but I'm running out of time here. So I'm gonna let it go. And if there's any questions, I'm happy to answer later. So I'll pass it on to Chyna.
Hi, again, I'm Chyna, peer recovery specialist. the role of a peer recovery specialist, we utilize our lived experiences with substance use and use that to connect with and support others wherever they're at with their use. Some of the things that I do at NACC, I work in the intensive outpatient program. I do a peer group weekly, and then do one-on-ones with IOP clients, and then I get referrals from other departments in NACC, and then outreach. And through one of the grants that I'm on, I'm able to do work at the hospital. So 2 days a week, I go, and so I work with the Fairview Addiction Consult team at the University of Minnesota Hospital. And there's 2 doctors who also work at the Community University Healthcare Clinic, which is in the same neighborhood as NACC. And there's a social worker and a peer. And so a lot of the people that I work with there are in there for like endocarditis or osteomyelitis or other IV drug use related infections. And there's a lot of overlap too with like a lot of people that I've seen, during outreach, I'll see in the hospital or vice versa. And also, a lot of NACC patients too I run into. And then I'm also able to like connect them back to services, because I can continue working with them and supporting them outside of the hospital. And I've gotten a few people into the outpatient program here, and just kind of continue like working with them and linking them to care. Chyna and James and I do a weekly harm reduction group. And so we were having like food and snacks, but now we're doing to-go snacks. And so it's like incentivized. Like we give them a $5 gift card for participation. And yeah, we talk about different stuff. We've done a few Narcan trainings during group, talk about stigma, how that affects us, and discuss like different like resource sharing. We've heard of a lot of stuff that people are utilizing in the community and able to like share that information with others. And I guess that's all I have, and I don't know who I'm passing it off to.
Thanks, Chyna. So the last few slides, we're going to go over ongoing challenges. And as we kind of close out the presentation, I want to invite my colleagues to unmute and chime in as they see fit. If you feel like I am not touching on something, or if you have something to add. So the first and possibly one of the most obvious ongoing challenge is the race rate disparities experienced by the people that we serve. And I know I'm kind of preaching to the choir with this, but just as a reminder that American Indian and Alaska Native people in Minnesota represent less than 2% of the population, and yet have outsized representation in these opioid overdose rates, and also HIV positivity rates in the current HIV outbreak. So I think as of the last opioid dashboard released by MDH, American Indian and Alaska Native people were 7 times more likely to die of an overdose than white people. And of course, this rate was published before the nationwide spike that happened in 2020 as a result of COVID. And so I don't know how this race rate disparity has changed. And as I said, overrepresented in the current HIV outbreak in Hennepin County and Ramsey County. And then houselessness continues to be an issue, and not just houselessness, but you know, James alluded to this, like the continued displacement of people who are living outside, just like these ongoing encampment sweeps. Another thing that Nikki and James talked about as well is stigma. So stigma within that people face among service providers, either in healthcare or, you know, homeless shelters, etc. And this is an infographic that I recently saw that is based on a study that was conducted on providers, and the providers who used the language on the right were more likely to have a negative perspective or a negative viewpoint on the people that they're working with, as opposed to those who used the language on the left. So substance abuser, even the word relapse or medication assisted treatment, which is still a word that's in regulation, but you know, I know that people are moving more towards MOUD. And even on this, I don't really hear people use this word, but pharmacotherapy instead of MAT. So if anyone wants access to this infographic, I'd be happy to share it. And then also COVID-19 and social unrest present as ongoing challenges, specifically those events, but also like any disruption really to like the social order sort of reveals how barriered the system already is, and also exacerbates those barriers that are already there. And so I included some links in here that provide some information about how opioid overdoses increased during COVID-19. And just a quote here that says, the COVID-19 pandemic has significantly emphasized the dangers of pre-existing racial and social disparities. And this sort of presents as just like, you know, during the pandemic and also during the social unrest that followed George Floyd's murder, like having to close down facilities, grocery stores were closed, encampments were like continuously being swept during that time too. And so when people keep getting moved around, it's sort of hard to maintain relationships with them as a clinic. So there's that. And then also, I think, you know, James and Riley already kind of alluded to this, but ongoing, or I guess that like more ongoing challenges are infrastructure, like a lack of infrastructure. We don't necessarily have like adequate dedicated space for syringe exchange in the clinic. And also something that we always have to keep an eye on is people using in our bathrooms. So if we're handing out syringes and people kind of just dip into the bathroom, we have to keep an eye on that. And I don't know, it's taken a lot of problem solving. And right now, I think the solution that we're at right now is that we have a light, like a motion censored light outside of each bathroom that I think it turns off when it's not. Go ahead, Michelle.
Yeah, so the lights in the bathrooms have a motion sensor. So if there hasn't been any movement for, I don't know, 2 minutes or 3 minutes, something like that, the light in the bathroom goes off. Now, the light inside the bathroom isn't always visible under the door. So what we have is a light on the outside of the door that also goes off if the light inside the bathroom has gone off because of a lack of movement. So it's just a way, so if you, or if I give a patient supplies, safer use supplies, and then I know that they have gone into the bathroom, or even somebody who just I know is in the bathroom, and then I notice that they haven't come out and the light is off, I'm gonna want to check on them. And then the light on the outside of the door makes it really obvious that like nobody's moving in there.
Yeah, this is a new thing that we're trying out. I don't know if it's the thing, but just always problem solving this. And then worker safety also. I don't know, I guess I can't really speak to data around this, but what we are experiencing, I guess outreach workers, especially in Minneapolis, is just an increase in gun violence, I guess specifically at one camp. It hasn't historically been an issue, but in the last year, it has become an issue for us that we have to talk about. And then of course, potential for needle sticks and then secondary trauma and burnout. So if anyone doesn't have anything to add to what I've said, we can just move on to questions.
Do you want to stop sharing, Tina?
Sure.
And then we can all see each other. Can I ask a question? Am I allowed?
I think so.
So great job like explaining all of the stuff. Like NACC has, obviously worked for a lot of years, gathering up lots of services and programs and supports. How would a clinic or a small organization start? I mean, if they wanted to just like step one and step two, what also like what supplies would be like the first things they'd want to hand out?
I think and maybe I think James would potentially be the best person to speak to like the base supplies if you're starting out small. A suggestion that I would also want to make is, again, like I said before, to get in touch with another organization that is doing this, just because it's like so much easier, I think, to enter into it with a little bit of some guidance and somebody else's experience. So again, you're welcome to reach out to us, but it doesn't have to be us, any place doing syringe exchange. But I don't know, James, if you want to talk a little bit about sort of like baseline supplies.
Yeah, I would agree with, and I know that there's been other conferences or whatever where this topic's been brought up, maybe even on echoes, and I know it can be challenging to get under that SSP funding through MDH. But at the same time, like let's say you want to do that, you have really no experience. I'm going to go back to that experience part because people out there know, and we want to make sure that we're being very genuine when we're out in the field, and because it does take time to build those relationships with people. It took me probably a good 2 years after NACC, as I was like, even though I did harm reduction outreach backpack type style in the past, it wasn't really in this area. So it took, like there was this white guy walking around, like, and this weird looking white guy. But having that experience is really great because now I'm able to sit there and they'd be like, oh, you stopped met, like I'll have those conversations about treatment centers or like my experience and so forth like that. Because I have had a lot of lived experience, but I like the idea. I do think like it's really wonderful that NACC is unique in the way that it's a clinic that does offer this type of outreach. I know Healthcare for the Homeless is doing all the time, and they're just amazing. And then their Clinic 555 in St. Paul have been doing it. But I would say if you're wanting to start it up, try to reach out to the folks that have been doing it, unless you have people on board that do have some history with it. And then and then after that, you can start navigating, like what supplies you need. But like, I will say this, that we at NACC do supply other organizations that do secondary exchanges with supplies, and we're happy to. I'm always happy to meet anybody and chat and get you some stuff. So please let us know if that's something that you're interested in, or if you know somebody that needs some stuff. And also, I just want to mention too that we don't limit the amount of syringes that we hand out to people. Our hope is that every shot is a different syringe, and that's when we go back to the displacement of camps. I might see somebody I haven't seen in a week, and I gave them 40 syringes, and they're gone. So again, hopefully housing first is like, it's going to be such a critical piece of harm reduction and so forth. But yeah, that's my long-winded answer.
I like the long-winded answer. Thank you. I think, in general at NACC, we're happy to share. So we're happy to share documents. We're happy to share educational materials. We're happy to share knowledge, stuff like that. Does anybody have any questions before we wrap up? Got about 2 minutes left. Feel free to raise your hand or put something in the chat.
For someone who's not currently involved in outreach, who would like to be involved, is there a way for like a current employee to volunteer or like come out with you guys or anything that we can do? Yeah.
Totally. We have like a whole schedule. If you want to reach out to one of us, or maybe a good place to get connected would be if you want to start coming to the outreach meetings every Monday, but we can connect after.
Yeah,
I was going to say everybody should do outreach. It's
I know
just,
me and
it's
Michelle
so
went
great.
out. Yeah, we went out one time. Yeah, we've had a number of different staff come out with us, and then also like different folks from other clinics. I've been out with Ryan in the past over at Kook, and it's kind of great too, because like we're able to maybe to offer also a broader spectrum of services when other people are there. So that a question might pop up that I or other people can't answer, and then this other staff member is like, hey, I know about that. But we also too like want to be conscious. I think a lot of people that are familiar with us, the back in the day, is like, if they don't know you, they might think you're a cop or something like that, and may not trust whoever's out there doing that, because that does happen, or at least it was happening in the past where undercovers would go out.
All right, so it looks like we're at 1 o'clock. Thank you everybody for hanging out with us. Feel free to email us, reach out to us if you have our direct numbers, anything like that. If you have questions, suggestions, you want some help with anything. So our next session is the 16th?
Yep, February 16th with Susan Bolio from the University of Minnesota, talking about ACEs and historical trauma.
Yeah, if you don't know about ACEs, the Adverse Childhood Events, check it out. It's amazing. And then join us next session to learn more. Thanks, guys.
Thanks, everybody.